Good morning. I would like to welcome you to the second roundtable, which is for novel prognostic and predictive indicators. Liquid biopsies has shown promising results from early diagnosis to detecting disease, to monitor therapy, also predicting the response, and also for the progression of the disease and recurrence. Liquid biopsies may play a larger role in the breast cancer clinics, so this panel is very interesting. And I would like to start with the first speaker, which is Michalis Ignatiadis. He's Chief Medical Oncologist in Brussels. He's Associate Professor at ULB, and his department is at Institute Jules Bordet in Brussels, and he's the Chief of Breast Cancer Group for EORTC. Mr. Michalis Ignatiadis, we're all ears.
Thank you so much. Good morning, everyone. It's a great pleasure to be with you today. I will try to make. So let me know if it's full screen and if you can hear me well. Can you hear me?
Yes, we can hear you.
Very nice. So I'm going to discuss about liquid biopsy for the detection of ctDNA relapse in early breast cancer. So these are my conflicts of interest. And so one of the challenges that we have today in drug development is that new drugs provide marginal benefit in unselected patient populations. And there are few biomarkers for treatment selection in breast cancer patients. On top of that, we have a limited understanding of complex disease biology. And so I'm giving you here an example of a study that was published some years ago in the New England. And basically this study tested whether extended aromatase inhibitors for 10 years were superior to just having aromatase inhibitors for 5 years as an adjuvant therapy. And what you can see is that indeed there was a benefit, but the benefit was very small. And you see that it took close to 2,000 patients to demonstrate this benefit. And of course, in our clinics, we use now for high-risk patients, node positive, especially those that have 4 or more positive lymph nodes. We're using this approach of extended up to 10 years adjuvant endocrine therapy. But then still the benefit in this population, still it's small compared to the 5 years of endocrine therapy. So, and this is a recurrent theme in drug development in breast cancer. In other words, we have to give a new drug, any new drug that we're testing, including, for instance, the new selective estrogen receptor degraders that are being tested in as adjuvant treatment in breast cancer. We need to give to the whole population for a small absolute benefit. So the question is whether we can do better than the current approach of doing clinical trials, in which basically we're selecting patients based on pathology risk, so like node positive disease, and on some key pathological features, could be even genomic features, such as high genomic risk signature, but still we fail to select patients for which the treatment can provide a big absolute benefit. And so the question is, to which extent the liquid biopsy can help us try to identify really those patients, and only those, that need this treatment escalation with new drugs. And so there has been some efforts in that area. I will mention one trial in triple negative disease, the Tractian study. That was a trial that screened women with high risk triple negative breast cancer using what I call a first generation ctDNA assays, so assays that were based on one or two mutations, single nucleotide variants that were identified using tumor sequencing with small next generation sequencing panels. And these one or two mutations were followed in plasma of these patients serially using droplet digital PCR. And in this study, patients that were ctDNA positive were randomized in a 2-to-1 fashion between either intervention, so pembrolizumab, versus observation. So this is an effort to exactly give the pembrolizumab to only those that potentially need it. And so let's see what was the detection rate of ctDNA. The investigators screened every 3 months for 1 year. And by the 12-month time point, so the starting point was after patients have completed surgery and chemotherapy, whatever the sequence, so either preoperative or postoperative chemotherapy. And as you can see, 27% of patients altogether had detected ctDNA. And basically, as expected, the majority of patients with detectable ctDNA were those that have high clinical risk. So for high clinical risk, we had 55% of the patients, whereas it was close to 12% for those with moderate risk. Now, this was presented at San Antonio 2 years ago and then published in the Annals. And actually, they randomized 45 patients, 14 allocated to observation, 32 to pembrolizumab. The problem was that overt metastatic disease was detected at the time of ctDNA detection in 72% of the patients. So eventually, only 9 patients were ctDNA positive and staging negative. 4 declined treatment due to the COVID pandemic that was prevalent at the time the study was conducted. And then only 5 started treatment with pembrolizumab. And basically, this was a negative study, and it shows that although in theory it's nice to hope that the liquid biopsy can help us achieve what I would call precision medicine in early disease, but it's not something that it's easy and straightforward. And we need to see whether liquid biopsy, for instance, ctDNA, can make a difference in that area and can help us achieve precision medicine in drug development in early breast cancer. Now, I'm going to quickly refer to second generation ctDNA assays. So not just looking for 1 or 2 mutations, but looking for many mutations. So here is a paper. This is one of the commercially available assays in which the investigators are doing whole exome sequencing in the tumor. And they select 16 variants that are tumor specific and patient specific, and they are not germline. Why? Because they are also sequencing normal DNA. And these 16 variants are being followed in plasma. So you see, we go from 2 to 16. And now there are also some companies that they are using whole genome sequencing in tumor, in plasma, and in normal. So whole genome, not whole exome. And this is another company called C2I Genomics that is developing this. And so they are really looking for many more mutations, hundreds of mutations or copy number aberrations or any genomic aberrations that are patient and tumor specific. So the question is whether this new generation of assays would help us identify those patients with molecular relapse or a term I like, ctDNA relapse, early on when imaging is not showing metastasis. So we used one of those assays, the Signatera assay, in a small study that we have conducted in my institution at the Jules Bordet. And the aim was to just gain some experience with these assays before entering and using them in the context of trials that will test their clinical utility. And so this was a cohort of 44 patients that have been treated with neoadjuvant chemotherapy. And as you can imagine, since this was a neoadjuvant chemotherapy cohort, the majority of patients, 2/3 had high Ki-67, and we had 30% triple negative, 25% HER2 positive, and then the majority of ER positive, HER2 negative were sort of the luminal B-like tumors with high Ki-67. And we have collected samples at baseline after neoadjuvant therapy and before surgery, and then serially post-surgery, including a last follow-up sample. Now, what we have shown is what it has been shown by others as well, is that at baseline, the levels of ctDNA were higher, as you can see on the right graph, in tumors with high proliferation. This has been repeatedly reported in breast cancer, but also in other tumor types beyond breast. The other thing that we have seen is that in triple negative breast cancer, we have seen also higher levels of ctDNA compared to the other subtypes, again, consistent with the notion that high proliferative tumors are shedding more ctDNA. These were baseline samples. Now, another interesting observation we made is that in multifocal tumors, or bilateral tumors, ctDNA assays, personalized assays that are based on only one focus may not capture the relapsing clone. And so we had one patient that had like bilateral breast cancer. It was patient 13 in this diagram. And you can see that we have sequenced for this particular patient, we have sequenced both tumors, the right and the left. So the tumor in the right breast and the tumor in the left breast. And we followed plasma ctDNA over the course of neoadjuvant chemotherapy. And then the dotted line here is surgery. And then after this is the follow-up samples. And what you can see is when this patient relapsed, and this is the red triangle, when this patient relapsed, actually we were able to capture the disease relapse only with the assay that was the personalized assay that was designed based on the right breast, whereas the assay that was designed based on the left breast was not able to capture the disease relapse because the relapsing clone was coming from the right breast, suggesting that in case of multifocal tumors or in case of bilateral tumors, and multifocal tumors, especially if there is different like immunohistochemistry profile or bilateral tumors, it could be the case that these personalized assays may not capture the relapsing clone unless all tumor foci are being sequenced. And of course, this increases the complexity and the cost for developing these assays. Now, what we have shown is that in this small series, that it was more important, the detection of ctDNA after treatment or at follow-up, rather than the detection at baseline. And this also makes sense. And it has also been reported by other groups. So we have this molecular relapse, this ctDNA relapse, which is ctDNA detection prior to imaging detected relapse, after curative intent therapy for early stage disease. But the question is, to which extent we have enough time between the detection of relapse, of molecular relapse, of ctDNA relapse, and the detection of metastasis at imaging, whether we have enough time to intervene and change treatment course. And so the questions here that we need to address is whether treating patients with this ctDNA relapse will simply delay the development of metastatic disease without improving overall survival, or this will lead to improvement in overall survival, and most importantly, whether this will improve the cure rates. So this is the big question that the liquid biopsy field needs to address. And then, of course, the other question is whether any gain will be justified by potential negative effects in the quality of life for patients that enter such screening programs for ctDNA, and then, of course, interventional trials. Because all these screening programs in women that have already finished chemotherapy and surgery might create stress, and we need to measure that in order to see whether the benefit-risk ratio justify this approach. And so at the EORTC, we thought that maybe we could focus on another tumor type. So maybe triple-negative breast cancer, due to its rapid disease evolution, might not be the best tumor subtype to test the concept of intervention based on ctDNA detection. Maybe ER-positive disease, we thought, maybe it is a more appropriate setting because it evolves less rapidly, so it's less aggressive disease. And so maybe there we have a larger window to intervene. On top of that, we thought that maybe we could focus also on patients that have already completed 5 years of endocrine therapy. So these are the patients that are not having early relapse, in which also in ER-positive disease, the early relapses are associated with aggressive disease. And so whether we can really select those patients that have endocrine sensitive disease, so that have received 5 years of endocrine therapy and have not relapsed yet. We do know that these patients are at risk of relapse at least up to 20 years from diagnosis. Some say maybe for their whole life. And then take these patients that are late in their disease course and do a screening for circulating tumor DNA using the Signatera assay. Now, this is wrong in the slide. It's not the radar assay, it's the Signatera personalized assay. And so we take very high-risk patients. So we take patients that are stage 2B or 3, either after primary surgery or that have this stage 2B or 3 before starting neoadjuvant chemotherapy, so clinical stage 2B or 3. And then they receive neoadjuvant chemotherapy and they have no PCR. They need to have, as I say, 5 years of endocrine therapy. And we can include in this screening program patients up to 7 years of endocrine therapy. We can accept, since this is a very high-risk population, patients that have received CDK4/6 inhibitors, as long as they have completed this treatment 12 months before enrollment. We don't allow patients to have received SERD or in the context of a clinical trial. And then if patients are ctDNA positive, then we do a workup, and we hope that in this setting, of sort of more indolent disease than the TRACT-TN that you have seen before, we may be able to have a lower percentage of patients that had detectable metastasis at the time of ctDNA detection, and potentially a long lead time to relapse. And these patients will be randomized between 2 years of elacestrant, which is a new SERT that has been approved in metastatic breast cancer, in ESR1 mutant metastatic breast cancer. So we're testing this new SERT in the early setting versus continuing the standard of care endocrine therapy for another 2 years. What we do offer to our patients is also in both arms, so also in patients in the standard arm, which they continue the same endocrine therapy, we offer them a close follow-up with imaging every 4 months, which is sort of not of what would have happened otherwise, so that we can eventually detect early on potentially curable or oligometastatic disease that can be treated earlier compared to what would have happened without this test. And so we do scanners every 4 months, we do bone scans every 8 months, and then we do also mammograms. And the primary endpoint of this study that will screen around 2,000 patients to randomize a little bit more than 200 is to demonstrate that we can decrease the rate of distant metastasis, so we can improve, other words, the distant metastasis-free survival, giving elacestrant versus continuing endocrine therapy in these patients that have endocrine-sensitive disease, have ctDNA detection, and are negative at imaging for both local or distant relapse. So this is a study. I'm very happy to say that the study would start in a month from now, in less than a month from now. So we hope to have the first site open in December. I'm also very pleased that we have Manolis Alustros, who is the investigator from Greece, who is organizing the sites in Greece, and he's co-PI with me in this study. We also have Wolfgang Jani from Germany, that is also co-PI in this study, and that will join this effort from Germany with a success group. We have 12 countries in Europe, and we have more than 120 sites that will be actively enrolling, hopefully, and all these sites, we hope to open them from now until the end of next year. I would finish by thanking you and by inviting you to join us in the 14th European Breast Cancer Conference in Milan. Since this is a surgical congress that we're in today, there is a lot of potential interest for this EBCC conference in Milan, because this is a conference that is focused on multidisciplinarity. So we're going to have a lot of participation and intervention from surgeons and radiotherapists. And what this new edition of EBCC is bringing is bringing innovation. So in the multidisciplinary management of breast cancer. So you are going to hear new data about the multidisciplinary breast cancer. The disclosure is that I'm chairing this EBCC edition, the 14th edition, but I would be very happy that you come and you enjoy all the nice program that we have put in place. So thank you for your attention, and then we'd be happy to take any questions either now or at the end of the talk, of the session.
Okay. First of all, good morning, Michalis from Athens, and thank you very much for your presentation. It's happy to see you once again, even from the distance. Okay. We decided, Michael, to have the discussion at the end of the
Okay.
presentations, because Maria will present the data that we have accumulated with the CTCs. So I would like to introduce Maria Papadaki. Maria Papadaki is PhD, PhD researcher in the Laboratory of Translational Research in the University of Crete. It is an old collaborator of me. So Maria will speak about the status of CTC determination and the characterization in breast cancer. Maria.
So good morning. Could you please let me know if you can hear me well? Can you hear me well?
We can hear you very well.
Yes, there is no problem.
So good morning. I would like to thank the organizing and scientific committee for the invitation, and especially Professor Georgoulias, who was my PI and my mentor for many years. And we in the laboratory are trying to continue his valuable research in the field of the liquid biopsy. And today in my talk, I will focus on the role of circulating tumor cells in breast cancer. So circulating tumor cells are detected in the peripheral blood of patients with solid tumors, and these cells are involved in the metastatic process. Their detection is a marker of tumor dissemination and poor prognosis in many cancers, including breast cancer. And it is important to note that the tumor cells can also enter the bloodstream from metastatic sites, which means that CTCs can reflect the whole spectrum of tumor heterogeneity. And of course, CTC analyses are important for tracking tumor evolution, which is promising to uncover the mechanisms of resistance and to identify new therapeutic targets. So I will start with the role of CTCs as prognostic biomarkers in breast cancer. Here are some of the first studies from our laboratory many years ago, where molecular assays were developed to identify CTCs. And these studies showed for the first time in large cohorts of patients that the detection of CTCs is a poor prognosticator, both in early and metastatic breast cancer. Now, using the FDA-approved cell search system that can isolate CTCs from the peripheral blood, many studies have shown the prognostic value of CTCs in metastatic breast cancer. And here is a large retrospective pooled analysis of more than 2,000 patients from different centers, including our department, showing that the CTC enumeration can very clearly stratify patients to high risk and low risk using the cutoff value of 5 CTCs. And it's important that this stratification is valid irrespective of the molecular subtype or the line of treatment or the type and the number of metastatic sites. And many studies also suggest that CTC monitoring during treatment or follow-up can provide further prognostic information. And this is well shown here in the large pooled analysis of 2,000 patient data, showing that patients that have high CTC counts, both at the baseline and a few weeks after treatment initiation, are those with the worst outcomes. And here they show that the early CTC changes can further improve the prognostic accuracy of the predictive models. And it was also for the first time clearly demonstrated the superiority of the CTCs over the common serum tumor markers for the prognostication of metastatic breast cancer. Now, in the early disease setting, there are many clinical trials showing that CTC detection is a marker of poor DFS and overall survival. And it is important to note that the persistence of CTCs after the surgery and the chemotherapy can serve as a marker of minimal residual disease. And particularly in this study, the detection of CTCs many years after surgery and systemic therapy was associated with a 13-fold higher risk of recurrence, which is quite impressive. So we know that CTCs have a clear prognostic value in breast cancer. However, an important question is whether we can use CTC analysis for treatment decisions. So many clinical trials have been designed to address this question. Some of them focus on the enumeration of CTCs, some others on the phenotype of CTCs. Most of the first studies were negative. Some are still recruiting. And I will focus on this positive trial, the STIC-CTC trial. Here, the investigators aim to compare the efficacy of a clinician-driven treatment choice versus a CTC-driven choice for first-line treatment between chemotherapy and endocrine therapy in a hormone receptor-positive, HER2-negative metastatic breast cancer. So patients were randomized to the standard arm for clinician-driven choice, and to the CTC arm, where patients with high CTC counts received chemotherapy, while patients with low CTC counts received endocrine therapy. And it was impressive here that in the discordant cohort of a clinical low risk profile but high CTC count, there was a reduction in the risk of death of almost 50% for those patients treated with chemotherapy because of their CTC counts, rather than endocrine therapy. That was the investigator's choice. So this is the first study showing clearly that CTCs can be an effective biomarker to drive the first-line treatment decisions in metastatic disease. Now, beyond enumeration, further characterization of CTCs is also important. We saw a very nice and clear talk by Michalis Vinantiadis regarding the clinical relevance of ctDNA in breast cancer. So it is a very sensitive and validated biomarker ready for use in clinical practice. So why should we use CTCs? So it seems that ctDNA and CTCs can provide complementary prognostic information in many cancers, including breast cancer. And the real advantage of CTC analysis is that it can be done in multiple different levels, not only at the genome level, but also at the transcriptome and proteome and metabolome level. And also these cells can be isolated as live cells, which means that can be functionally analyzed, which is also very promising and opens the research perspectives. In the next few slides, I will show you some studies performed in our laboratory on CTC phenotyping. So here, you may know about the clinical tumor dormancy, which is related to late recurrence in breast cancer. And in this study, we monitored CTCs in patients that were disease-free for at least 5 years. So we analyzed their samples at different time points during this period, and every 1 year until the relapse. And it was interesting that all patients with CTCs had CTCs in a likely dormant dormant state, meaning that they did not express either proliferative either apoptotic markers, while apoptotic CTCs were mainly identified in the non-relapse group, while proliferative CTCs were more frequent in the patients that relapsed, and these cells further increased during relapse. So this study shows that monitoring the profile of CTCs could have a role as a tool for predicting late recurrence in breast cancer. So it's also widely accepted that the cancer stem cells and the epithelial to mesenchymal transition, EMT, are hallmarks of cancer and metastasis. In this study, we developed an assay to identify in parallel these aggressive features on CTCs of patients with breast cancer. And it was interesting that there was a great heterogeneity of cells in early and metastatic disease. However, there was a population of cells co-expressing these aggressive features that really prevailed in the metastatic setting, suggesting that this could be an aggressive population involved in metastatic progression. So next, we evaluated the effect of first-line chemotherapy on CTCs, and we showed that CTCs co-expressing these aggressive features were the only cells that increased after chemotherapy. And their increase was significant only in the HER2-negative breast cancer and among patients that did not respond to treatment. And also their detection was a prognostic marker associated with reduced survival rates and was also an independent factor predicting for high risk for disease progression and death, which means that these cells could be a chemo-resistant population with poor prognostic value for breast cancer patients. And then we evaluated whether the eribulin mesylate, another type of treatment, could have an effect on these cells, since there are in vitro and in vivo data suggesting that this drug can reverse EMT and can also eliminate cancer stem cells in breast cancer. And we show here that indeed these aggressive cells can be completely eliminated 8 days after treatment initiation. However, it seems that they reappear at the significant level during disease progression. And again, the detection of these cells was of poor prognostic value in these patients. In another study, we showed that patients that have CTCs in their blood, and especially those that have the STEM EMT CTC population, also had increased levels of immunosuppressive circulating cells in their peripheral blood. And we found interesting associations with Tregs levels and MTSCs levels, which could mean that CTC detects the presence of CTCs may be associated with a dysregulated anti-tumor immune response in the periphery, which is very interesting. We also know that the anti-tumor immune response is a dynamic process. It can differ among the primary tumor and metastasis. So in this study, we evaluated two immune checkpoints, CD47 and PD-L1, that have a key role in anti-tumor immunity. And we analyzed in parallel the CTCs and tumor cells of primary tumors and metastatic tissues of these patients. And we found that these immune checkpoints can be co-expressed on CTCs. This is first evidence suggesting, and the detection of these cells was of high prognostic value associated with high risk for progression and high risk for death. But a very interesting finding here was the very low concordance in PD-L1 expression between CTCs and the primary tumor, which is interesting considering that anti-PD-L1 inhibitors have been already introduced in the treatment of triple-negative breast cancer. And this is something we are now evaluating, the value of assessing PD-L1 and other immune checkpoints on CTCs rather than tumor tissue in patients with triple-negative disease. And finally, another study here, we explored two other molecules, TLR4 and STAT3, that have a key role in the cancer inflammation and immune evasion. And we showed for the first time that these molecules are expressed on CTCs in breast cancer, and they are also associated with poor survival rates, which means that the TLR4 and STAT3 signaling could have a role in metastatic progression of breast cancer. Now there's another system, the Parsortix system, a platform that has been designed to specifically isolate CTCs from the peripheral blood. And in this large clinical trial, the system was evaluated for its compatibility for downstream analysis of CTCs at different levels. So since last year, the system is FDA cleared for CTC isolation and downstream analysis in metastatic disease. And here is a nice example of using this system for multiplex gene expression profiling. And finally, the functional analysis of CTCs is also feasible. Many groups are using functional assays like such as cultures or xenografts to analyze CTC. This is very promising to identify those features that are directly related to the metastatic capacity, and also for drug screening to test the treatment efficacy and to identify new targets. Of course, we should note that there are several pre-analytical and analytical steps that need to be standardized for the incorporation of CTCs in clinical practice. For example, we don't know yet which is the optimal blood volume for the detection of these very rare cells in the blood, especially in the early disease setting. Also, there are many CTC markers. However, one marker cannot detect all the CTC populations. Also, there is a great variability of different assays for the enrichment and for the detection of CTCs, and the selection of the right assay is also a challenge. And with this last slide, I would like to mention that the perioperative CTC enumeration can be used to determine cancer cell dissemination during different surgical procedures. And in breast cancer, data are quite controversial. There are some studies suggesting that CTC counts increase on the first day and during the following 3 or 4 days after surgery. However, these studies are included small numbers of patients. And in this prospective trial of 400 patients, there was no increase in CTC counts 1 week after surgery. And finally, in this blind trial of 100 patients undergoing either endoscopic surgery or open radical mastectomy, it was shown a slight increase of CTCs in the endoscopic group and a more pronounced increase in the open group. However, these differences were not statistically significant. And so we can see that CTC counts may possibly serve as a marker of cancer cell dissemination for the assessment of different surgical procedures. And this is the summary conclusions of my talk. So the detection of CTCs holds significant prognostic implications for breast cancer patients. Further analysis of these cells can provide insights into the heterogeneity of the tumor and the mechanisms of metastasis and resistance. Of course, standardization of pre-analytical and analytical steps is required for using CTCs in clinical practice. And to address all these issues, there are several international and European academic industry collaborations and consortiums that have been established to optimize the CTC assays, and with the goal of conducting a multi-center study. And we have to say that large interventional clinical studies are required to really demonstrate the clinical utility of CTCs in breast cancer. And it is also interesting that the perioperative CTC enumeration could serve as a tool for the assessment of different surgical procedures. And I would like to thank all our collaborators and you for your attention.
Okay, thank you, Maria. Thank you very much for this comprehensive presentation of the status of CTC's, let's say, research. So, are there any questions from the audience? Are there any comments? Yes, please.
Η ερώτησή μου θα είναι στα ελληνικά και επειδή οι ομιλητές είναι Έλληνες, πιστεύω θα το κατανοήσω. Γνωρίζουμε αυτά τα κυκλοφορούντα κύτταρα από πού προέρχονται μετά από μια επιτυχή χειρουργική ή μετά από μια θεραπεία γενικά, δηλαδή όταν αφαιρεθεί ο όγκος. Είναι κύτταρα τα οποία έφυγαν από το πρωτοπαθή όγκο, είναι κύτταρα τα οποία έφυγαν από ένα θετικό λεμφαδένα που δεν έβγαλε ο χειρουργός ή από μία μεταστατική αιστεία την οποία δεν γνωρίζαμε.
Okay, Maria, would you like to answer?
Ναι, θα προσπαθήσω να απαντήσω. Λοιπόν, τα δεδομένα δείχνουν ότι τα CTCs μπορούν να προέρχονται είτε από τον πρωτοπαθή όγκο, είτε από το λεμφαδένα, όπως λέτε, είτε από μεταστάσεις σε απομακρυσμένα όργανα. Τα δεδομένα επίσης δείχνουν ότι αυτή η διασπορά των καρκινικών κυττάρων μπορεί να γίνει πάρα πολύ αρχικά, πριν καν τη διάγνωση του όγκου, πριν καν την αφαίρεση του όγκου. Τα κύτταρα αυτά μπορεί να μεταφερθούν σε απομακρυσμένες αιστείες και εκεί να μείνουν ακόμα και στο λίθαργο ως μικρομεταστάσεις για πολλά χρόνια. Επομένως, το origin, το από πού προέρχονται αυτά τα κύτταρα, μπορεί να έχει πολλές απαντήσεις. Δεν ξέρω αν θα θέλανε ο κύριος Ιγνατιάδης, ο κύριος Γεωργούλης να συμπληρώσουν κάτι πάνω σε αυτό.
Okay, the question for Professor Hahn, the question was which is the origin of the circulating tumor cells, and the answer from Dr. Papadaki is that these cells are disseminated before the diagnosis, before the existence of the tumor. Okay, since they could be from any site, probably the primary tumor, lymph node, they are circulating cells, micrometastatic cells all over the body. Okay, and we have our group have already demonstrated that these cells could be detected in the blood even before the involvement of lymph node. Okay, we can find these cells in the bone marrow spirates even before the primary surgery and after. Even if the lymph node is histologically and immunohistologically negative for remaining cell or for detectable isolated cells. So, if there is no other question, I would like to call Professor Hahn from Tübingen to comment on the two.
It's Professor Michael Onch. Is the chair of interdisciplinary breast cancer department in gynecology at Helios Clinicum in Berlin.
Thank you very much. So Michael and Maria, first of all, congratulations to your presentations, both of you, and for your scientific power you are showing since many years in the scene for holding up with these very important topics. Now let me start with a general comment, and maybe it relates even to the excuse me, it relates even to the last comment from Professor Gorgulias. And this is a negative comment. We had a huge scandal in Germany several years ago when a chair professor from Heidelberg claimed that they have developed a test from the blood of normal women, and they can tell them whether they will have breast cancer or not. Now, this has not shown to be true, and we have to be very careful because already now some companies are going into the same direction. Now, this is number one. Number two, comments to both talks. Michael, I think the EORTC 29 study is exactly going into the right direction. Why? Because you pick up a patient population and you also pick up a clear mutation, which is the ESR mutation, and we have the drug elacestrant, which has been approved by European authorities several weeks ago, which is showing very nice results in metastatic breast cancer, but just in those patients who have a ESR mutation in the ctDNA. So my question to you, Michael, and then I also have a question to you, Maria, is since we know that already now almost 20 to 20, almost 30% of the patient in the ongoing or just finished trials, Monarch A and Natalie, one with the CDK4/6 inhibitor abemaciclib, the other one with the CDK4/6 inhibitor riboxiclib, still have relapse and metastasis, although they have received the optimal combination of endocrine therapy with CDK4/6 inhibitors. Are you excluding those patients who are under current CDK4/6 endocrine combination in your ERTC study? And if yes, why?
So thank you very much for these questions. We are not excluding them.
Okay.
So these are, so patients can receive either Ribo or Abema. The only thing is they need to have finished this CDK4/6 inhibitor treatment at least 12 months before. Now, the assay is a personalized ctDNA assay, so it does not necessarily need to have ESR1 mutations.
Okay.
It could have or it could not have. So this is also another clarification on so we're not including only patients with ESR1 mutations, because this is based on a personalized gene panel that is derived from the primary tumor of the patient. So these are, I guess, the two points that you have raised. I don't know if I answered your question.
Absolutely, absolutely. Thank you. So, Dr. Papadaki, thank you very much again for your presentation and also your scientific power with your group. You know, you have to fight many years in a topic at which you haven't fulfilled the last step, which is ESMO recommendation or NCCN or ASCO recommendation, but it might come and it will come. The question I have for you is related to the one study which you have shown with the checkpoint inhibitor signal in CTCs, because we have seen very nice results from ESMO several weeks ago in Madrid by Fatima Cardoso with the addition of a checkpoint inhibitor, pembrolizumab, in patients who have luminal B cancer, which obviously was not on our target in the last years because we thought, oh, just the triple negative patient, just triple negative breast cancer is immunogenic. So now we know that also parts, and this is my point, also parts of the luminal breast cancer might have the checkpoint inhibitor signal. Would your platform allow to select for those patients and give just those patients pembrolizumab? You are muted.
We cannot hear you.
Excuse me, can you hear me now? Okay. So our data from 200 patients with early and metastatic breast cancer show indeed that PD-L1 expression can also very frequently express on CTCs of luminal patients and on HER2-positive patients as well. However, as we saw, there's the need for large clinical trials in order to prove that the expression of immune checkpoints on CTCs can be a select marker for immunotherapy. It's not that simple. So yes, there are the technologies that can allow the very sensitive and specific assessment of immune checkpoints on CTCs. However, I think we have a long way until we go there to use this information for selecting immunotherapy. I don't know if I have answered your question.
Absolutely. Thank you so much. Thank you.
Thank you very much. Now we would like a comment from Dr. Nasioulas, who is a scientific director of GeneCore.
Thank you, the organizing committee for giving me the opportunity to comment on the nice presentation of Dr. Ignatiadis and Dr. Papadaki. I mean, the detection of circulating tumor DNA is a technological challenge, and it seems from what Dr. Ignatiadis presented, we have a first generation, which first generation based on limitation of next generation sequencing. We had a few mutations. Now we have, in some platforms, we have the molecular profiling of the primary tumor of the paraffin block based on whole genome. This is one technology, but there are also other technologies like methylation, which is a feature of cancer cells to follow. With other words, I mean, for the ones of you that they don't, I mean, have a picture what means circulating tumor DNA is a tumor DNA, and we have to see the flux of tumor, which are mutations, methylation, etc., etc. This is the one comment for the presentation. And since we are a lab with experience in liquid biopsies with circulating tumor DNA, I will focus on the talk of Dr. Ignatiadis. And it seems there is a big body of evidence today, Dr. Ignatiadis, that suggests that the circulating tumor DNAs in different tumors like breast cancer, ovarian, colorectal cancer, there is a prognostic marker telling us that we will have a recurrence, that we have a disease that we cannot detect with the imaging systems. And we have now, and you have shown now data and trials, we have to prove whether or not this circulating tumor DNA is a predictive marker suggesting that by giving appropriate therapies, we have better results. But it seems that we are in this direction, I mean, to prove that this is a predictive, which is the ultimate goal of the oncologist. And okay, and the third point, and I'm stopping here, is the cost of liquid biopsies right now, because you need big machines, you need reagents. The cost is right now not extremely high, but it is a little bit high. But based on competition of different companies, the cost will decrease, and we will all have experience with the cDNA, tumor DNA, as to follow the minimal residual disease, because for other reasons, for detection of mutation like EGFR is now in the clinical praxis, and thank you.
Okay, okay. We reach at the end of this table. I would like to say that to make a last comment. I believe that liquid biopsy is the future in medical oncology. In medical oncology, in oncology in general, and can help us to understand how we can approach the treatment of the patients. Despite the limitations, the technological limitations that we have, we know that cancer is a heterogeneous disease, and we know that there are questions which are not yet answered. However, the evidence that we have and the studies that we have, the majority of the studies regarding either the cell tumor DNA or the CTCs demonstrate that the detection of these two parameters, DNA or CTCs, are predictive for the outcome of the patients. And in small studies have also shown that taking into consideration the presence of these markers, or this more specifically of CTCs, could help us to monitor and to adapt our treatment. We have published in 2012 a paper in Annals of Oncology, and randomized study of HER2 negative patients, ER positive, who had residual CTCs after the completion of adjuvant chemotherapy, early disease, completion of adjuvant chemotherapy, but these patients had HER2 positive circulating tumor cells, and the patients were randomized to receive or not trastuzumab, and we showed and we demonstrated disease-free survival, and better disease-free survival, almost 90% of the patients with the residual cells after the completion of adjuvant therapy. I note this. So despite the limitations that we have and the problems, the technological problems, there is a strong effort to improve the technology and to make the situation more easy. We know that the detection of these of liquid biopsy, even ctDNA or CTCs, are bad prognostic factors. Okay, there is no doubt about this, and from my point of view, we have to use and to combine the two parameters, not only one. The information you have with only one parameter, CTCs or cell tumor DNA, are not the whole image of the situation of minimal residual disease. So we have to open our ideas how to comment, to approach this parameter of circulating tumor cells and of the minimal residual disease. Okay, with this small comment, I would like to close, if my co-chair is agree, this session, and I will thank Michalis and Maria. Both of them are close collaborators and my collaborators for many years. Both were trained in my department, and I'm glad to see them to progress. And I would also to thank the organizers and my co-chair and all of you who followed this session. Thank you very much.
Thank you.